I mentioned that the importance of stage shifting in early disease as a result from low-dose CT screening. Would you please explain some of the current experience in Canada with low-dose CT screening? In the United States, the rates continue to be lower than we would like and only slowly increasing, which is frustrating for such a potentially life-saving test.
Yeah, we've been working on this for quite some time, a lot like what's been going on in the US. In Canada, it tends to be provincially adjudicated. So we have some provinces that are further down the road of having formally established screening programs. Ontario was the first to get that afoot. Now we have one that is on the verge of being deployed here in Quebec, and there are several other provinces that are moving in that direction. We definitely see those patients coming through, but because we're still so early in the deployment of this pretty broad effort, I don't know that we've really generated statistics to know where we stand, say, in comparison to some of the efforts in the States. There's no doubt that getting patient engagement for these types of efforts continues to be a challenge. We see that, but there are more and more patients coming through our clinics who've been identified through these efforts and for whom we're offering, exactly as you've described, an opportunity for curative treatment.
Great. So just to level set for our audience, can you speak to the evolution of adjuvant and neoadjuvant therapy when it comes to lung cancer surgical therapy and explain the perceived benefits and maybe some of the potential risks of this approach?
Well, our efforts, and I say the big R with a big O, have been longstanding for many years. And I always quote the first couple of studies in the early 90s. The one was out of the Spanish cooperative group led by Rafael Rosell, and the other one was led by the MD Anderson group with Jack Roth. And those two studies published in 1994 showed that when you added chemotherapy to surgery for stage 3 disease, you just had a very dramatic impact in terms of survival. And both those trials actually had to be stopped halfway through because of the benefits of adding a systemic treatment to a local modality. And then really 30 years have gone by of trying to pair all of the different options, surgery, chemo, radiation, and then introduction of new treatments into that mix. But it's been sort of rearranging chairs for 30 years. Do you give it before? Do you give it after? And it's what do you give? Is surgery really required? What's the role of radiation? And I would say there's been nothing truly definitive up until more recently in that space. There have been incremental steps forward. But I think it's been very exciting because we're in a period where we're really starting to see the benefits of all the innovations that are happening in the metastatic setting now influencing what's happening in early stages. Because we recognize that issue, that despite our efforts to properly stage patients and say, oh, okay, this is localized disease, it's curable, we're still struggling to really tease out who are the ones who have micrometastasis, who need these treatments to prevent a subsequent recurrence, and who are the ones who do just fine with a purely local therapy.
Yeah, I was surprised to see that statistic of 30 to 50% of people with stage 1 having surgery still have a recurrence rate of that high, which is concerning and certainly speaks for why you've developed some of the treatments you have.